Hi, welcome to Detours Understanding Acquired Brain Injury. Today, I'm going to be talking about the disease of traumatic brain injury, the chronic illness that is traumatic brain injury, looking at it from 30,000 feet, as it were. Now, the thing is that acquired brain injury, and traumatic brain injury more specifically, isn't a singular event. Most people do, like when they hear about it, if they hear about it on the news or hear about it from, the assumption is that traumatic brain injury is just once and done. I mean, you're in an accident or assaulted or, something happens, that's it. But traumatic brain injury and acquired brain injury generally is a chronic, lifelong illness. And it affects not only the survivor, it affects their family, it affects their community. And these interact with each other, the symptoms and the mechanisms. And evidence is beginning to show that it is an illness that goes from generation to generation. Now, that kind of stuff is a bit beyond the scope of this video that I'm going to be talking about. And in this video, I'm going to be focusing on primary and secondary, the mechanisms of brain injury. And I'm going to be doing it kind of in a story format. And later I'll be talking about tertiary effects long after the initial incident that set things off. But there's evidence also that there are things that set one up for traumatic brain injury even before you're born. And this is what I'm talking about, that, it potentially goes down the line. And that you might say genetics and epigenetic factors that make me more likely to have a traumatic brain injury, acquired brain injury. Yes, that's exactly what I mean. And it may raise an eyebrow, but we'll be talking about that too. Some people are more likely to have, not just based on their habits, but based on certain vulnerabilities that they have in their genes, certain disorders, other disorders that make them more likely to experience a traumatic or any of the other disorders. We'll get to that, but here's what we're going to do. Let's get started. One of our hosts, a young lady who has allowed us, and her mother's allowed us, Amy, you may have seen her introduction, suffered a significant, severe traumatic brain injury in a motor vehicle accident. She was a backseat passenger when her car was hit by an 18-wheeler. And the driver was not alert, was not focused, or something. Can't say what happened, but we do know that for some reason something went wrong, and this 18-wheeler hit a car full of young people. And Amy, who is one of our hosts, one of our video hosts, and her mother, Amy was thrown forward in the back seat. Her seat was dislodged. She struck her head, and she suffered a severe TBI. This is Amy before she was hurt. She was 16, and she was ready to become, it was close to her birthday, almost 17. And so age is one of the factors that plays into how well or not you will do. The research is kind of equivocal, but we know that in the long run, kids don't do as well as adults do with traumatic brain injury. And when you're in your childhood to early adulthood, and it's kids, young adults, so from teens to late 20s, are most likely to suffer a severe traumatic brain injury, as well as adults over the age of 70. These are two primary populations that suffer traumatic brain injury, statistically. Now, there are other groups that are more likely to suffer traumatic brain injury, and they are obviously in your 30s and 40s. Your chances are a bit higher because of motor vehicle accidents also, but that's a small blip. The largest are the teens and the elderly due to falls, and changes in brain morphology, and kids because they're just learning how to drive, they're new on the road, sports-related incidents, CTE, things like that. So these are why. Every day in every state, and you'll hear me say this a lot, 5 people in every state in the United States, 5 people in all of those states, so more than 250 every day, suffer severe traumatic brain injury. And the numbers are even higher for moderate and mild TBI. Check out the Glasgow Coma scale. What's important to remember is that the Glasgow Coma scale does not reflect really what your outcome is, and it does not reflect, even survival necessarily. It really was a tool designed in the 70s to help physicians to prepare the ED, the ICU, to know what kind of things immediately. And it's not used the way it was intended to be used. It was intended to be used, you would take it about half an hour to an hour after the patient arrived and use it to decide, whether they would need to go to intensive care, which was a new concept back then. And emergency medicine didn't even exist yet. Emergency medicine wasn't a specialty till 1985. And so oftentimes you'd have young docs who were interns, their first year in residency, whatever, they get stuck down in the shock area, whatever the ED was back then, and they would handle. So this kind of helped them organize with what to do, where to go. It's been misused. And what really you want is the Glasgow outcome scale extended to help you predict. But now we've got other tools. All right, so after whatever's happened, after the initial incident, within a few milliseconds, many different things happen. So after Amy was struck, after her vehicle's hit, and this is what happens in motor vehicle accidents in general. First thing that happens is I'm going to use the skull here with the top off. When you are thrown forward in a motor vehicle accident and struck or side, there's acceleration and deceleration that happens because, Newton, our friend Newton. The thing is, your brain has a very different density from the skull, because the skull is kind of a hard box. It's much denser than your brain is. Your brain is soft tissue. It's kind of like jello. And your brain then is thrown forward and back, and it will bounce around inside your skull. And the thing is, because its density is different, and the brain itself has differing densities inside and on the outside as well. And it will be pulled, stretched, and torn. And you will get bruising on the brain. So you'll get what are called contusions, bruises on the brain, on the surface, usually on the frontal lobes, as it is thrown forward in the skull. And you will get bruising where the initial impact is first. All right, that's important to know. But there is more that comes later. And unfortunately, because of the shape of the skull and where there are bones, the sphenoid wings here, and there's a lot of rough surfaces inside your skull. This is accurate. So you will bruise and you will have tissue damage in areas that are very important. This is why a lot of people lose their sense of smell and taste afterward. where these white structures are the olfactory bulbs, help with sense of smell and processing, as well as taste. But these areas down here, a lot of behavioral functions, the orbitofrontal lobes and parts of the temporal lobes as well lie. And these are some of the first areas damaged. But a lot of impulse control, and that's kind of like knowing the social rules and riskiness of behavior are controlled here. And these are some of the areas that are damaged in virtually all traumatic brain injuries. This is why you get a lot of the behavioral, the acting out, the problems with, why somebody may just take something without thinking about it. They may speak without, holding back what they say, because damage here. In those areas, they may have problems with moral behavior. They may be kind of like disconnected from the world around them. They may seem kind of apathetic and stuff. Some of that is damage to that area. All right. Anyway, we'll get back to that in a moment. So the initial contusions in the brain. Meanwhile, you also have damage to the skin. Of course, you'll have lacerations and tears and things. And you also damage, there are 12 nerves that come off the cranium, cranial nerves. And you will get, that's all happening at the same time. These motions are happening at once. So while you hit your head and you're thrown back and forth, and the brain is being contused, or contusions, you also are having bleeding and black and blue marks, and you are going to fracture the skull sometimes, and you may get cerebrospinal fluid leaks. This all happens within a few milliseconds to seconds of when you're hit, like, again, in like Amy's case. But here's a person who has damage to cranial nerves. Their eyelid droops, and there's some black and blue marks, things like that. And here are 12 cranial nerves. These have an effect not only here in the face, or the eyes, ears, sense of smell and taste, not only from olfactory bulb damage, but damage to the nerve itself, but they also affect the heart rate. They affect respiration, digestion. These cranial nerves are important, and a link to that dysautonomia that you've seen and talked about, and that we've talked about here, because of damage to those nerves. There are other factors that affect, like the hypothalamus, and damage to the pituitary as well. But all of this happens almost immediately. But there are other factors that play a role too. Next, after this initial hit blow, after the initial contusions from bouncing around inside the skull, you also have to take into account that you typically tear blood vessels too. So you'll have bleeding inside the brain. Here, looks like this. Vascular tears and bleeding into the meninges. Outside of the brain, there are coverings called the meninges. This is what, when I've described meningitis, there are thin coverings that protect the brain from infection, things like that, and damage of a very mild sort. It's not heavy-duty protection, but it's to protect. And if that is torn or broken, and there are blood vessels that lie in it, damage to these blood vessels, your skull can fill quickly with venous blood, arterial blood, if you tear an artery. But this can change quickly, with a motor vehicle accident. You can end up with epidural hematomas, EDH, and that puts pressure on the brain. And one of the problems is that your skull is much more rigid than your brain is, and there is two choices for giving way. Well, you've also got cerebrospinal fluid. So fluid, which is non-compressible, skull, which is non-compressible unless it's a lot of force, or brain, which is compressible. Guess which will give way? And there are different places for the brain to do what's called herniation, which is to squeeze through a narrow opening. If your brain tries to squeeze through that opening, down here at the bottom, you could see on this model is your brainstem, where your vital functions, the signals for your vital functions are generated. Respiratory rate, your heart, your breathing, all that good stuff. If that tries to squeeze through that narrow opening and destroys those neurons, guess what happens? You die. So this is why, in order to prevent your brain from herniating, squeezing through that opening, they will drill a hole into your skull to allow it to expand out through that, or take a piece off, so that it expands up and out there, as opposed to trying to squeeze through that opening and herniating and killing you. This is why intracranial pressure, within cranium pressure, that relates to secondary injury zone. I'll get to that in a moment. All right, next, you also have problems with when you are in an accident. You'll have your coup, your strike, and you'll also have the brain, when it bounces back, contra coup injuries, which are bruising on the exact opposite side, because that energy has to go somewhere. So hit, and your brain will bounce back. And so you'll get bruising on the opposite side. So if you hit the back of your head, you'll also do damage, guess where? Frontal lobes. And if your brain is shaking around, bounces inside your skull, or side to side, same thing. If you do damage on the left side, you also will do damage on the right side, because it's a coup, contra coup, it's a bounce. And so coup meaning strike, contra coup or counter coup meaning opposite strike. And almost always you'll see that where there's damage to the front, there'll be damage to the back, which is the occipital lobe, which processes visual information. All kinds of effects from that. Color distortions, perceptual distortions, not understanding objects when you see them, not knowing what a fork is, for example. If you see it, but if you pick it up and touch it, you may recognize it, but you can't tell what it is by looking at it. Hallucinations and object distortions from that. But you also then will have frontal lobe damage, the coup, contra coup, so you'll have behavioral problems and problems controlling attention and focus and memory, working memory. And that's from, again, that primary injury, okay? And that's next. I'm going to talk about microvascular damage. Now, this is much harder to see or detect. Blood vessels throughout your brain, again, this is the first few moments, microscopic, the capillaries, the venules, and the arterioles, and little tiny blood vessels, are torn and destroyed. And this is a problem for, obviously, because of lack of circulation, and they'll often clamp down, they'll cut off the blood flow to healthy areas of the brain. But it's a reflexive kind of action. And this damage leads to massive destruction throughout the brain. And because these make up the blood-brain barrier, they allow large molecules into the brain and bigger cells that shouldn't be getting in there. Macrophages and other kinds of inflammatory markers, which lead to some of the damage from secondary brain injury. And these inflammatory markers indicate that healthy neurons potentially should be destroyed. So disruption of the blood-brain barrier, we're discovering, is a significant component for brain injury. But as soon as you've hurt your brain in a traumatic brain injury event, you're already headed down that road towards significant injury later down the line. And it's something you can't do anything about this in an accident or anywhere else, because these things happen in the first few moments. And to make matters worse, once these microscopic, or these blood vessels open back up again, the sudden flooding of oxygen and nutrients and everything back onto cells that are wounded or injured, the neurons, they begin to self-destruct. So they're destroyed when there's no oxygen, and they're destroyed when everything opens back up and there is oxygen, food, and nutrition. So you get it going both ways. And so damage to skin, face, bones. There's damage from the contusions, damage from coup contre coup. There's damage from vascular and microvascular bleeding and bleeding into the skull itself. Elevated intracranial pressure, which begins, but it takes a while before you start to see edema, which is a secondary cause of damage. And also, you see diffuse axonal injury. I have a separate video on that one. But diffuse axonal injury and shearing of axons. The axons, this is what that looks like right here. Diffuse axonal injury comes because axons are the long myelinated, it's kind of insulation, if you will, for allowing different parts of the brain to talk to each other. We now understand that the brain is basically a series of networks, different areas of the brain that talk to each other collaboratively and work together to make you. But you need to link these different areas, the different regions of gray matter, together so that they can all compute together. It's like an internet, if you will. It works like that. This is an example of some of those networks. But with traumatic brain injury, diffuse axonal injury is one of the main sources of destruction. And it happens during those first few less than seconds. They're pulled, torn, twisted, and stretched, and broken immediately in the accident that you're in. And disrupting those networks basically prevents your brain from being able to collaborate different regions and affects anything from emotional regulation, focus, attention, the ability to plan, think ahead, to take the perspective of the other person, to do all these different things, to see, to hear, to understand what you're hearing. Language functions, the ability to understand abstraction, and the ability to recognize objects, the ability to come up with a novel song or whatever, to read, to do mathematical calculations. All of these things are dependent on networking. And if you disrupt these white matter tracks, and to make matters worse, over time, there's self-destruction that happens, even more neurons and things, due to secondary effects. But the initial diffuse axonal injury happens in the moment that there is a physical trauma that happens to the brain. So the initial diffuse axonal injury and the lacerations, that happens at the moment of the incident, from the throwing of the brain back and forth inside the skull. It may seem tight, like it fits, but the movement of the different densities of tissue is what causes this tearing and ripping and laceration. And the brain also is twisted too. And depending on how much energy is applied, even more destruction. And there are different grades of diffuse axonal injury, or you can call it traumatic axonal injury, which is technically a more accurate term, traumatic axonal injury. Grades 1, 2, and 3. I suffer grade 1 to grade 2, where you move from just on the cortex, and it's important to know that, like with diffuse axonal injury or traumatic axonal injury, most of grade 1 is here on the cortex, on the top areas, the cerebrum, basically, the areas where higher functions take place throughout these layers. Grade 2 is much deeper, happens not only with the cerebrum, the top layers, but also happens down into the corpus callosum, which links the two hemispheres together and allows sharing of information in much wider areas. And so disruption there will affect the whole individual and all their different skills, not just isolated specific skills, but throughout. And when you're starting to see damage there, bleeding there, and things like that, you notice definite personality and behavioral changes beyond isolated ones, but pretty much throughout. And you'll notice they have academic problems, cognitive problems, emotional problems. Finally, grade 3, diffuse axonal injury, whatever, that affects down into here. And a person who suffers grade 3 is immediately unconscious, and they have damage down into the upper reticular activating system down here, which has projections up into the cerebrum, the upper areas of the brain. And when that's disrupted, they fall unconscious and they will remain unconscious. It won't be a momentary disruption like diffuse axonal injury 1 or 2 or confusion. A person with diffuse axonal injury or traumatic axonal injury will be momentarily or maybe confused for a while, have memory and focus. They'll show some of the symptoms, but they won't be unconscious for a protracted period of time. Disruption down here, those are the people who remain in a coma for days, weeks, months, and remain so. And some never wake up. Others, it takes a long time for those axons to reconnect and stimulation to bring them out of these altered states of consciousness. But this disruption happens, these disruptions happen immediately. And so there is, based on imaging, a traumatic axonal injury or diffuse axonal injury 4, 5. Most people who have this do not survive. Most die. Some do make it, but they have severe disabilities. And it takes a long time to heal. Some do get better, but they do have more significant disabilities. It's not impossible to heal from these, but these disruptions are significant, whether it's diffuse axonal injury 1, 2, 3, or 4. But if you have these, and most of us do who are in motor vehicle accidents, who suffer whatever, if you have diffuse axonal injury of any grade, you're going to have significant and lasting disabilities. The question is, can you accommodate to them? Can you? That is primary traumatic brain injury. What happens before the ambulance even gets there? This is what happens. This is like, it's done. It's over with as soon as, it's happened. And these are lasting damages. And there's nothing really at this point that we know of to do for that, because it happens before you're even, before the medics get there, before anyone can help you. If you crash or somebody hits you, or are hit in football, or you're a victim of domestic violence, this is stuff that happens before you even get help, because it's within a few seconds. Now we're going to talk, in the next video, we're going to talk about secondary brain injury. And this is stuff that we're working on that maybe we can do something for. But this damage is just as devastating. And the problem is, right, as of now, we really don't know much how to help this either. This is the stuff that happens when you fall into a coma or are wandering around and kind of confused in the days afterward. And this can go on for hours, days, weeks, months, years. And it just worsens your condition significantly. Primary injury is bad enough. This just adds to the complexity and complication and makes what would be maybe mild or moderate severity into severe with much more significant brain injury. So I hope you'll join me for the second part, which will look at secondary injuries due to traumatic brain injury, and often in acquired brain injury. The pattern that unfolds is similar. So please subscribe, hit that bell icon. Any comments or questions below. This next video will be interesting because it involves less of the overall brain and it's more microscopic. It's what unfolds at the cellular level and some at the tissue level, yes, but a lot of this is what goes wrong with the cell now, with the neurons. Remember, neurons only make up about 10%, 15 depending, but about 10 to 15% of your brain mass overall. But many of these malfunctions happen within the neuron and some of the surrounding supportive cells that help your neurons do their business, as it were. So come back and watch part 2, because this applies to traumatic and acquired brain injury as a whole. And I think you'll like what you see. And so again, if you have any questions, please comment below, and